Morning, Daniel. How's it going?
Hi, good morning, Evan. I'm doing well. How about yourself?
I'm doing okay. It's cold here in Portland. I think it's going to be like a high of maybe 75, but it's 55 outside and 54 in my house right now. So,
I had the furnace guy come by this morning. Our heat was out, so also cold here in Pennsylvania. Glad to get that fixed.
you got that, and then the wedding coming up. You are just having to burn all all fires.
Yeah, I
All
guess
right.
for everyone listening, I get married this weekend, so exciting week ahead.
Yeah. All right. Well, we are back for our second front end or patient access conversation for a podcast. So I think it is a good time to introduce a couple new people, maybe that are sitting here on the video for our video watchers, chuckling along with us.
I can start us out then with introducing our first guest. Always excited to talk patient access, and we got a great crew of folks here today. So for our first guest, though, is the current president of the National Association of Healthcare Access Management, or NAHAM, in case you've heard NAHAM and not the actual spelling out of the word. And then along with NAHAM, the day-to-day job is the Director of Operations at Children's Hospital, Colorado. And then with more than 25 years in patient access operations, she led the Children's Financial Counseling Department to become the second hospital in the state to become a presumptive eligibility site for Medicare or Medicaid and CHP plus, which ultimately reduced application processing from 180 days plus to 30 days. We'll talk through some other examples here in the call today, but I am just really honored to have you here, Stephanie Benintendi. Thanks for joining us today.
Yeah, thank you so much. I'm honored to be here today. Pleasure working with you guys today. Thank you.
All right. Well, I get to introduce our second of three guests today with 20 years of progressive leadership in the access services and ambulatory patient care. They are the current vice president of NAHAM. They're also serving on the faculty in the Department of Health System Management at Rush University College of School of Health and Science. They have operational oversight of access centers, including analytic capacity management, ancillary scheduling, referral department, pre-registration, and the list goes on. And it is an honor to welcome the Vice President of Access Operations from the University Medical Center, or Rush's University Medical Center. Welcome, Philip Quick.
Thanks, Evan. Great to be here with you. Super excited to be part of this amazing podcast.
All righty. And then I guess last but not least, Daniel, should we tag team this one?
Yeah, that sounds good. So our third guest, Wilshire favorite, has been here we've been working in the industry for 16 years in the revenue cycle and access management. Been a key operational leader for more than 8 EMR conversions, which is more than me, and has served as the regional director of admission services, where they won the 3-time HFMA MAP award, winning for multi-specialty health systems in East Texas. Evan, I'll pass it back to you.
Yeah, they're also a former director of NAHAM, a board of directors. They are our current director of people and culture here at Wilshire. So welcome, Tim Holland.
Thank you both. Happy to be here.
All right. So Stephanie, Philip, and Tim, we're going to start out just a little bit of background about patient access as part of this series of podcasts on the patient access experience and journey. We're trying to encourage our listeners to think about where patient access was and where it's going towards and what that has morphed alongside the change in healthcare. So look to you all for your experience, your background, and where you think the industry is headed. Maybe Stephanie, we can start with you just to give us a little bit of background on where what comes to mind when we talk about that.
Yeah. So, when I think back to when patient access was, when I started, it really was all about data entry, and we were considered data entry clerks. And our job was to basically translate anything from a piece of paper into the computer system, whatever it was at that time. We've certainly see that shift over time where we became a little bit more sophisticated. We got more technology. We started moving more into EMRs. And we had more of a health data record set as opposed to just independent pieces of paper that were collected for a medical record. We shifted more into pre-registration and making sure families were scheduled and pre-registered ahead of time, but it was all manual. It was a phone call. It was phone tag back and forth trying to get all that information. After that, we saw a little bit more movement into now let's make sure everything is authorized. We always assumed that the physicians were doing it. And as we started to get more sophisticated in our data analytics and realizing that maybe those authorizations weren't necessarily particular to the service that they were having at our hospital, we had to get a little bit more sophisticated as well. We then saw more and more centralization over time. We started to see that, you might still have multiple check-in locations, and instead of them reporting to the lab and radiology and the cardiodiagnostic center, they're starting to now centralize and come together to be more unified under patient access. And as part of that, then you started to see more of that consolidation of those functions. So whether it was scheduling or check-in or reg, all of those different pieces started to kind of come into it, and we really started to evolve. Now we're getting into understanding the bigger scope of what really front-end patient access looked like. As we got closer into probably the mid-2000s, 2010-ish, we started to see a lot of movement in terms of technology with eligibility checking. Instead of having to make the phone calls or using the old, I'm dating myself with some of this, but we had the old, looked like an old credit card machine, and you would manually type in somebody's user or their subscriber ID, and a little ticket would come up and tell you all their benefits and eligibility. We would use that for patient identity. But it was just these long strings of tickets that would come out, and you'd have to staple it to your paperwork. And the microfiche for patient identity if we were in downtime, and all those things we have now shifted to where we now have a digital front door, and patients are able to self-schedule. They're able to check themselves in either on a kiosk or maybe their own phone or a tablet. So I think seeing that shift even just in the past 25 years has really prepared us into the place where we now are we're a force in the revenue cycle for front-end patient access. We control the patient-family experience. We control so many different aspects. And, if we're going to get a denial on the back end, I could talk probably an hour on that alone. But it's amazing to see how this has shifted over the past 25 years.
Maybe I'll just add a little bit. Stephanie gave a really great overview of all of the things that I would echo and I've seen over my last 20 years in access. And, when I first started back in 2001, patients checking into the emergency room had these little credit cards. That was their patient identifier. And we would stamp them on sort of this 3-ply carbon copy paper that we would hold on file. And that was our patient identification system. So we've come leaps and bounds over the last 20 years, which is just incredible what technology has done. I think in addition to all of the technology, what has been really amazing to see is sort of the career ladder and the career progression over the last 20 years. And, when I started, and I know Stephanie echoes this, there wasn't these senior level positions. It was unheard of to have a vice president of access. There also wasn't a career ladder, or although NAHAM existed, the rallying around professional development and certification wasn't what it is today. And so to see that progression and to be able to partner, and during my intro, Evan, you mentioned I'm on faculty at our university, and I co-teach practice management operations, and we plug in access, and it's amazing to see people be able to choose careers that are lifelong and can make this a dedication of their career for their professional life. It's really amazing. The other thing that I think I'll add to what Stephanie said is the change really in the last couple years and sort of our shift to ambulatory. And Stephanie and I live this every day in our day jobs at our employers. But we're really seeing this shift as value-based care has shifted, and COVID has really pushed a lot of care on the ambulatory side. We're now seeing not only organizations catch up, where nearly half, if not more, of their revenue is on the ambulatory side from ambulatory day surgery and all of the professional charges and fees that go along with that. We're now seeing the shift and sort of focus not only on patient experience and the digital front door, what Stephanie mentioned, but also the entire ambulatory access to care and how that is done and managed, and moving all of those services upstream so that we can manage that patient pre-service as much as possible.
And just from my comments, just to kind of blend those two things together, Stephanie, you talked about, things transforming into a digital front door, and then Philip, you talking about how the career ladder has kind of evolved over time. And this has been kind of a necessity just because of the demands and the asks of registrars and anybody in the access realm today versus what it used to be maybe 15, 20 years ago. It really was a data entry job a long time ago, but now you're asked to, you come in at an entry level job and you have to know the ins and outs of insurance. You have to know what an authorization is supposed to look like. You have to not only know how to generate an estimate, but then explain that estimate with good detail to the patient. And so it's the career ladder really has to be a necessity in order to kind of attract very intelligent, very qualified individuals to these types of roles. But even your entry level jobs, it's no longer a minimum wage type job. It's more like a $15, $20, $25 an hour starting pay, which is very exciting in my opinion, just in terms of where the career is going to go.
Yeah, and just to add to that too, Tim, I think the other part of that transition of having more of a more educated, higher educated person than what we used to have before is now we're starting to see the master's degrees, the bachelor's, the master's, in some cases, some people even have the doctorate. And you have to factor that in, not only from an educational standpoint, but we're also asking them to actually be on the front line still and have that face-to-face interaction with patients and families to be able to, create that experience, that inviting, welcoming encounter when they come into your hospital. So I think when you have to pair those two things together, that's what makes this very unique, is you don't typically see frontline, and they're not frontline by any stretch of the imagination, but because they are first person the patient sees and interacts with, they're still considered that frontline area. But the expectations on them behind that are just astronomical. We didn't see those levels of education and dedication and years of service that we've seen now.
And thinking about this, maybe expanding into the future, like 5 years, I know we talk about patient access. That's like a really wide umbrella, and we're talking about career ladders. Do you see that there being a shift in what maybe the career ladder looks like in the next 5 years, as far as like somebody in the world today or somebody entering today, and what that transition would look like? Or do you see it still being like a larger patient access umbrella that everybody sort of rolls up into?
If I could jump in, I think you're already starting to see it a little bit. The digital front door is really just starting to, get out and kind of evolve and become its own thing. So as patients start scheduling themselves more, doing their own registrations more, the last little remnants of data entry outside of maybe your emergency rooms kind of goes away. Now you're looking at more specialized type work where you are talking about interacting with more of an insurance company and knowing the ins and outs of what's required for an authorization, or knowing how to generate that estimate and being able to explain that to a patient that quite frankly knows that they have insurance but may not realize what the benefits they have and how that plan interacts with the particular health system you're working for. So yes, you're going to see that evolve even further, to where the job descriptions start becoming a little more demanding. You're starting to look for more high skilled individuals, which I think will only help the patient more. But from a patient access leadership perspective, it's going to be significantly harder, I think, to be able to recruit and retain individuals that already have that kind of a knowledge base.
I agree. And I think what we'll see, and we're starting to do this at my own organization at Rush, is adding in positions to be able to support that digital front door and the digital engagement that we need to have with our patients. And there's sort of always going to be, at least for the foreseeable future, a need to have, in-person folks and people answering the phone and scheduling them and pre-registering them. But as we shift more and more and more and put even KPIs in place to increase that interaction digitally with our patients, we're now seeing new roles. So it's sort of an additional career ladder baked into Access that are dedicated to support that, whether it's a real live chat person. So if you're interacting with a bot and you have an escalation to someone in Access that can help schedule you, help pre-register you, answer questions about insurance that maybe the AI bot couldn't do. Or from a program management standpoint, and how does that leader help position Access at the front door to make sure that we're accounting for all of those things that are part of patient access.
So I'm going to throw you guys a curveball as you're talking about people changing and morphing and having, going from frontline entry. Because I can remember, entering into healthcare, like your frontline entry was, being a file clerk in medical records. If you're going the HIM route, or if you're going the billing route, you started off as the person moving the green bar reports and helping stuff envelopes and bills and things of that nature and working in the mailroom, that type of deal. And then, really kind of that frontline patient access. But as we're starting to see a shift also in our environment, true environmental shift, with Hurricane Ian and all these other areas. And we're also seeing a larger increase of behavioral health populations coming through our emergency departments or even just for appointments. Are you guys looking at how do you partner with social work and things of that nature, or giving those crisis management skills to your frontline staff members, because they're really the ones when that patient walks in that has to de-escalate a situation if it's escalated right out of the gate, right? And what does that look like for your future as you guys are planning, future growth and how you're giving your team members toolkits? What does that look like, or what have you been doing given, a pandemic and then monkeypox thrown on top of that and people freaking out over that, and then Hurricane Ian coming through for a lot of areas that are being impacted? Just kind of trying to think what's that, progressional that might not be going back to school for a career ladder of an actual degree or even a certification, but even just that, real-time toolkit.
Yeah, that's a good point, Evan. I think we've definitely seen a lot of conversation coming around wellness and resiliency, and how do we equip our teams to be able to handle all of this? Because in the middle of COVID going on and all these other things, there's so many other aspects that are still coming out. We still saw legislation come out, at least in the state of Colorado, around, it was the early version of No Surprises Act, and it was the state local thing. So we still had all these other pieces that we had to deal with, in addition to trying to figure out how to work from home and how to do, just managing through the pandemic. And what we did, actually, this was before the pandemic, and we started to put our teams through it, it's called it's a de-escalation class from a workplace violence perspective. And so putting them through, depending on their role, anywhere from 4 to 8 hours worth of hands-on scenario-based training with our key, we have a resiliency and professional development department that put this stuff together and gave them real-life scenarios that you've got somebody coming at you at the front, they're upset their appointment was rescheduled or canceled, they're waiting 4 hours in the emergency room line, those types of things. And so running them through those types of scenarios gives them some of those pieces and tools to fall back on. So when something happens, they at least know how to react in the moment. And then after the fact, if it's something of significance, we have what we call is like a rest debrief. So we're able to bring them back. Let's talk about it. Let's break down what happened. Let's give you the tools so that you feel like you can learn from this and move on, and not have to always second guess everything that you did. Did you do something wrong? Was there something that escalated this? And give them that free space to grieve or to feel that it's okay that the way they reacted, and you can only control your own emotions and not how somebody else is handling it. So we've been running people through that. I think now that we're through the pandemic, it's time to re-up that, because some of them, haven't been through it in 2 or 3 years now. So we're starting to move more in that direction. And then from their support side, what I was going to say earlier is not only do our teams have to be that frontline person to understand the benefits and the eligibility and the estimates, but we are starting to take on more of that, almost like a family navigator role in connecting people to resources in the community. Do we have food insecurities? Do we have other issues at home that are really preventing them from following up on their care? And so partnering with social work, partnering with our population health teams. And that's where I really start to see our roles start to shift, is we'll start to continue to be the gatekeeper to identifying those families who need to be referred on for further resources. So I think putting all that together just continues to combine and escalate what the role of the patient access person is going to look like in the future.
I agree with everything Stephanie said. And I think most organizations that I've interacted with, we've seen sort of programmatically those de-escalation strategies and programs that are now being access is being pulled into, which is great, because the access wasn't always pulled into. It was very much sort of a clinician focused or a tech focused initiative. So it's reassuring to see now that we're at the table. I think one of the gaps that I'm seeing is really sort of almost the phone de-escalation, right? Particularly in our remote workforce. And, I have 168 schedulers that are completely remote. And how do we not only maintain their engagement from a remote workforce standpoint, but also give them tools and strategies that we can teach them remotely to de-escalate calls and be able to help them navigate through. And if you need to step away for 5 minutes from the phone, that's okay, because tough calls are going to happen. And we shared this last week in another call with my own team that patients post-pandemic are less patient, and I think we all are less patient, and it's just sort of the world we live in. And so continuing to think about how do we replicate the strategies that we're putting in place from a wellness standpoint and a resiliency standpoint, and replicating that from a pre-service standpoint, I think is going to be our next journey.
Yeah, and just to add some other color of what we're hearing from clients and from other people as well, we're hearing that they're starting to think about in behavioral health facilities and behavioral psychiatric emergency departments actually having some of their patient access staff be licensed social workers. We're seeing in transfer centers the actual case managers now having a full seat so that they can check for meeting inpatient criteria prior to a transfer coming in, and being able to screen or say, let's triage them in the ED first instead of doing a direct to bed placement, those types of things, and that partnership. So you are seeing those areas of access and that access management now really starting to embed clinical work for actual clinicians into their teams and into those throughput processes more so right out of the gate, versus saying, hey, we have this brand new college grad and they have no skill set yet. Let's just tell the patient to calm down. That's not going to work, right? So really trying to get that. So I think it'll be interesting to see how it continues to evolve. Before we continue the conversation, though, we do have to take a quick break. So we're going to take a quick break and we will be right back.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
Vine Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vinemedical.com. That's VYNE medical.com. And we're back.
All right. So we're moving on to our next section. We're going to call this NAHAM Rise and Shift to Ambulatory. So thinking about the outpatient space. In this section, or this segment, we're going to discuss industry trends, out-of-the-box ideas, and topics that get you thinking. All right.
All right, guys. So I know you both are now dealing, as Philip mentioned in the first portion of the segment, more of a shift to ambulatory culture where most people thought patient access was hospital focused only. So what does this shift look like and how's it kind of progressing?
I think I'll kick us off here. I think it's multi-pronged. I think that the biggest shift is sort of the structure and from a reporting structure and a leadership and a centralization of all of those access activities that we've worked on over the last 20 plus years on the hospital side, and putting those structures in place so that we're mirroring those processes, we're gaining the economies of scale and the efficiencies. And as I mentioned previously, as we see the revenue shift from inpatient to outpatient, that we are strategically putting those people and processes in place along with technology to minimize denials, maximize pre-authorization, ensure that all of our patients are fully verified and pre-registered at the time of scheduling. What I will also say, and this is sort of an anomaly that I've seen occur in my own last 3 years in the profession, is this huge shift in the patient experience and the emphasis on access to care and how patients are contacting your physician's office, how scheduling is working. And it's been this phenomenon at my own organization where the access questions on our Press Ganey ambulatory survey are now the heaviest weighted domain. They make up for 22% of the overall weight of the entire survey. They're weighted heavier than our questions that are asking about the nurse or even the care provider. So it just sort of goes to show that access has this profound impact, not only on revenue management and ensuring that we're having those patients come in expeditiously and from a clean registration, and so we can have a clean claim go out. But the experience that patients are now requiring, we have to be able to put our focus and resources on the ambulatory side because patients are just now expecting it.
Yeah, to kind of add to that, I mean, to me, it's kind of sad that it's taken as long as it has to start focusing on ambulatory in some ways. A lot of it, I think, is money driven, and that, you have this shift to ambulatory. And because of a lot of the best practices and centralization and standardization that you've seen on the hospital side has generated so much success, they're actually needing to replicate that now on the ambulatory side. I think it's a great thing that's happening. I think it's the motivation's all from the money side, but it is very much something that I think will benefit patients. It will benefit healthcare systems in the long haul to have KPIs like NAHAM use, or like organizations use with NAHAM access keys and things like that in the ambulatory realm. I think is going to be super beneficial from an accuracy perspective, from a collections perspective, in a lot of different ways. So I'm happy to see it happen, and I want to see it grow as much as we can.
Yeah, I mean, I think historically, hospital versus ambulatory has been high dollar versus high volume. And you're always going to put your effort where the high dollar is, which is the hospital-based services. But now that we're starting to see more and more care transition over to more of an outpatient setting, you still have the high volume, but it's increasing the revenue, and starting to see those in-clinic procedures, those downstream revenue impacts where that patient could be referred later on for surgery or an inpatient visit, or maybe needing to come back to your emergency room or something like that. So I think that's where some of that shift has happened. And as the industry has evolved over the past several years with that technology, you can now actually accomplish those same pre-service functions much easier, because now you can, if they're eligible and they're just here for an office visit, you don't have to do as much legwork in terms of an authorization, or estimates are a different story now, but you don't have, you could pre-do all that stuff through the system and just let it kind of run its course and not have to have anybody physically touch it. So I think moving more and more of that ambulatory work into the revenue cycle is where we started to see that shift. And now we just have to become more sophisticated, because now we have to put in the estimates, we have to put in more work around auths. But we'll learn, and we're getting there day by day. So it's good.
Are you seeing that, historically ambulatory has reported up through clinics and that component? So how is the blend, or, what advice do you have for our listeners and viewers on, first kind of steps or actions to start to evaluate blending, traditional patient access of an acute setting and the ambulatory setting, so that they're really combined, especially if you're all on Epic and that portion, but even other EMR systems, we're seeing that integration and how that's, forcing the change of coming into the same type of alignment. But how have you actually gone about doing that, outside of the theory?
Yeah, I think that there's a handful of different reporting structures out there, and I think the biggest piece of it, whether you report to revenue cycle up through your CFO, or in my case, I report to our COO. So I'm part of the operations team that oversees all of the ambulatory clinic operations. I think regardless of whatever reporting structure you have, it's the centralization effort, right? So, taking all of the people who do that work, whether, previously it was in the clinic, right? So you have people trying to schedule in the clinic, trying to do pre-registration, but not very well. They may not have the ability to do insurance verification, and they're not very good at collecting point of service collections, or collecting a deposit, and doing that work, establishing those KPIs. But it's really about taking the people and identifying who should be doing the work and where should it be done. And really what I've seen is best success is that centralized model, because you gain those economies of scale, you gain the standardization. And I think it's regardless of whatever reporting structure you have in place.
Yeah, where clinics tend to have a lot in order to catch up is that they typically were their own little house, their own little umbrella, and that everybody within that particular clinic reported to the clinic manager. So you would have a different version of KPIs or metrics that were important to one manager versus another, and typically access would fall very far down that particular totem pole. And that lack of standardization and, quite frankly, lack of education in some sense really hurts the clinics in terms of making sure you give a strong access process. So moving towards this centralized model or a standardized model, at least in the ambulatory setting, really does depend a lot in terms of how you have the organizational structure set up, and then also the training structure within those individuals.
Yeah. And most of those ambulatory clinics were independent, right? So they were their own sort of independent company that now may have gotten acquired or merged and you into a part of a much larger medical group. And that's really where you see sort of this culture shock and this pivot to be able to standardize and change management cannot be underscored enough in those areas where you have to partner with not only the operational folks, but those physicians and physician leaders have to be your partner as well through this centralization effort. Because if they're not your partner and they don't have a seat and voice at the table, you'll have a hard time being successful.
Just thinking about some of the tools, I'm at a go live, or was at a go live last week, and we were having some of these issues like in the outpatient ambulatory spaces come up, and we were looking at reporting tools for KPIs, and everything was focused on the clinic managers. To your point, like it was very decentralized, very hard to engage with everyone because there wasn't that centralized approach to operations. Maybe to put a plug for NAHAM out there, where do you see NAHAM being able to partner with this effort of like centralization, or bringing everything together and partnering and educating folks on that process?
Yeah, that's a good question. NAHAM really has understood in the past few years that ambulatory is really an area that we need to spend a little bit more time on and make sure that we are really serving as that key subject matter expert within the patient access community. And so all of our different groups, from the access keys to our education team, publications, everybody is really starting to take a look at whatever toolkits or the access keys, for example, that's in their wheelhouse, and really starting to evaluate it from an ambulatory perspective. So again, we've always been hospital-based in a lot of our material, and really now taking a look at it. And if I have this metric for authorization rate or pre-registration rate, does the good, better, best number on that access key really makes sense from an ambulatory perspective? And so each group is now starting to go through those so that we'll be able to put out those revised metrics, if they are revised toolkits, those types of things, to really start to get people to think a little bit differently about the ambulatory space. So we anticipate a lot of that work happening here in 2022, so that in the 2023 time space, we can really start releasing that out to our members.
I also don't think I can.
Oh, go ahead.
That's enough. Sorry, I feel like we kind of started at the same time there. Networking within and amongst other access leaders, the ability to do that with NAHAM, the fact that NAHAM puts on an annual conference, and also some of the smaller conferences that you would have across different states and everything. We're not the only access leaders that have ever gone through an ambulatory centralization project of some kind. That's happening all over the country. So being able to connect and touch base with other access leaders across the organization, get different ideas and different approaches, that has always been one of the most valuable assets, or arrows in my quiver, I should say, in terms of how I'm going to approach things at whatever organization I happen to be working for at that particular time. So definitely a plug for the annual conference there. Shameless plug at that, but it's definitely one of the most valuable things that NAHAM does.
Tim, you took the words out of my mouth. I was going to put two plugs. One for the annual conference, which is May 2nd through the 5th in Orlando, Florida in 2023. And we are looking for learning labs right now. So if any of our listeners out there have had success stories that they would be willing to share at our annual conference and put in front of others, where other access leaders can learn and hear and ask questions and identify those best practices from an ambulatory standpoint, I highly encourage you all to submit a learning lab proposal, which you can find how to do so on our website.
So thinking of those shameless types of plugs, how has NAHAM actually started to branch out outside of the traditional areas? I mean, I'll be honest, I had a little bit of the front end in my operational career reporting up through me, but I didn't really know about NAHAM. It wasn't until I had the pleasure of meeting Tim and meeting Patty and really getting to learn. I mean, I knew of it surfacely, but I didn't really know how it would benefit from me or, benefit my team in comparison to HFMA or other major national healthcare associations out there that, that also have awards and rankings and things of that nature. But kind of how do you see NAHAM, differing and benefiting, the whole organization, not just the access front portion of the organization? Because I think that's what struggles, people struggle with in the financial state that most hospitals and health systems are in right now is, where do we put our buck for our team members, and what's the difference, and how does that come back and benefit the full revenue cycle, not just their individuals?
Yeah, I'm glad you asked, Evan, because, NAHAM is really the only national association that supports the front-end patient access professional. We focus not only on the revenue cycle and everything that we've already talked about over the past, half hour or so, but we also really focus in on everything that is coming into scope for a patient access leader. So that could be the operational components. We all just went through COVID, and there were numerous COVID webinars that we held over the past couple of years for people to come together, share their ideas, what's working, what's not working, how did they make the transition into that new world. We have disaster preparedness. So now with Hurricane Ian that just came through the Florida area, there's a lot of work that you can do to be prepared as much as possible. And we have toolkits out there. We've had various webinars all the way back to when Katrina came through in New Orleans. And, and there's always things evolving in the industry as well, right? So we recently saw and are still seeing a lot of work around diversity, health, inclusion, health equity, and inclusion. We see a lot around identifying our patients correctly so that they feel valued, whether it's through the SOGI workflows or gender identity or just supporting the LGBTQ community. So I think there's so many different aspects. And if you go to even our education webinar page, you'll see hundreds of topics that have been covered over the years that help kind of guide you in some of those areas. And we're always nimble and flexible. So if the members say, hey, we're struggling with this, we need help, we're able to quickly pull together a group of people to address it, whether it's through a webinar or a toolkit or whatever. We have the NAHAM access keys, which Tim mentioned earlier, which has been out there now for a number of years. We're on version 4 and actually getting close to releasing version 5, hopefully with the ambulatory component to it. But it's those KPIs that you want your leaders to really be familiar with and able to benchmark themselves, not only against themselves, but against their peers. And it gives, a broad range between the good, better, best metrics. We have connections and the collaboration opportunities through the Access Forum and our listservs. We have a quarterly Access Journal, the NAHAM Connections. We have a content hub. We have policies out there for you to use. So if you're not sure where to start, at least gives you a place, and don't recreate the wheel if you don't have to. And networking, Tim mentioned that as well. You get that through the annual conference. Many states have local affiliates that we are trying to get back up and running again post-pandemic. So you can start to connect with people in your local area and deal with whatever the challenges are that you have more locally as opposed to nationally. So creating those connections and networks, honestly, is what got me where I am in my career today. Had I not had those connections and met Nancy Farrington at my first conference in 2004, I don't know that I would be here today. So there's just so much that you can learn from other people that have been there, that understand it, and you really can talk true talk. This is your shop talk. These are the people who know exactly what you're going through. We also have certifications. So I don't know that everybody is aware, but we have 2 NCCA accredited certifications, the CHA, which is for the Certified Healthcare Access Associate. And then we also have the CHAM, which is for the manager. And those are, because they're accredited, they are very substantial. They're not just easy tests that you can get through. And it really shows that level of commitment, not only to the field, but to the profession and to you as a leader. It always covers those changing topics, the different regulations, best practices. So you really get a sense of what patient access is like when you sit through one of those exams. And then just to give one last plug, we are working on a number of things right now, but some of the big things that are really going on are around our prior authorization. And NAHAM has actually taken a stand this past year in creating a white paper and trying to create some buzz in the industry and getting some payers to the table to talk about how do we reduce some of the administrative burden around authorization. We know it's never going to go away. And as much as we would like to really advocate on that side, we know there still has to be some checks and balances in the system. So we're advocating for how do we find ways to partner together so that we can create what that new path is going to look like without waiting for somebody else to establish it on our behalf. whether from a governmental perspective or, other regulations that may come out. So they have created the white paper. I would highly recommend checking out on the website. They did a phenomenal job, and Michelle Fox, who was our previous past president, and Becky Peters have really led this effort and done tremendous work in getting these people to the table. We're also recruiting and engaging the access professionals, as we talked about, in our ambulatory setting. So that's another huge key strategic focus for us in the coming years. And I mentioned the state affiliates. If you are in a state that does not have an affiliate or has an affiliate that is not yet re-engaged, please reach out to us. We have regional delegates that Philip helps oversee, that we would love to partner with you and help you get your state chapter back up and running. This is, like I said, that's the easiest place to get started at the local level. It gets everybody together, and then from there you start to gain the benefits at the national level as well. But get those local affiliates up and running. We would love to partner with you on that. And then we talked about the various networking opportunities that are out there too. So when you think of all of that I just rambled off, in the past few minutes, the value that you get for that, for even just our member fee, is significantly less than any of the other organizations. Whether it's the AHAM, HFMA, any of those other groups, our fees are substantially lower, and you get top quality industry best practice type stuff. So if you want a return on your investment, this is where you go. This is where you can put in that tiny little bit of money per person for the membership, and the rewards are just tremendous.
Stephanie, I got a cool little access key story for you.
Okay.
So, it was mentioned in my bio when I was introduced that I come from an organization back in my operational days that was a 3-time HFMA NAP award winner. But when we started going through that particular process, for anybody that's gone through it, it's not an easy one. And we started looking at the access metrics that you needed to get into there. We had already been practicing access key compliance and making sure we had those KPIs for a number of years. So when we started looking at the data and started doing the calculations like HFA1, it was like, oh, Tim's ready to go. Here's your data. And that was all it was. But the only reason we were like that was because of the access keys. So another shameless plug there, but that's something that I was really proud of with my organization at the time.
Yeah, I appreciate that. And I think you'll see that our standards are a little bit different. Some of our definitions are different as well. But I think we're really focused in on the actual pieces and parts that make up each of those access keys, where I think HFMA has something that's, yes, you need to have some of those front end metrics, but for them, that's not necessarily the driver of how everything ends up, where we're solely front end focused. So everything you see is what we do. Yeah.
All right. Well, on that note, we need to take another quick break, and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
And we're back.
Now it's time for the Wilshire Lab.
In each episode, we'll explore questions submitted by our listeners. This week, we have 2 questions raised by some listeners.
All right, I get the first question. And for this week, we're going to chat about patient estimates. So for our 3 guests here, just leverage your expertise and experience. Where have you seen your organizations or just other examples that you've heard around in the industry address aligning patient estimates for hospital and professional services, specifically for services you might not conduct? And then what should we all consider when moving to Epic's patient estimates, if that's something that you've taken on?
So I can talk. Go ahead. Nope, you go right ahead.
I was just going to, and Tim, you may have more to share than I do. I think, I've been a little bit spoiled in the last couple of years in the aspect of estimates and what isn't accounted for. Because I come from a very large academic medical center, and our medical group is comprised of not only primary care and then all of the specialists and subspecialists, but also ED, our radiologist, everybody's employed, which is great from a standardization standpoint. And it also makes it super easy to be able to account and have that price transparency from a price estimation standpoint when we're attempting to provide that service for a patient pre-service. So we can account for the hospital-based services, and I can account for the professional fees on all of those areas, because all of those physicians are employed and we have their fee schedules.
Where I was going to come in, I think this question alludes a little bit to the No Surprise Act and how this is going to kind of change the estimate world. I would say, I mean, it already has, but definitely in the near future as well. Organizations are going to be required to start providing estimates or some type of information around what the independent surgeon coming into the organization is going to charge from his professional fees, in addition to your surgical fees or organization's fees for having an inpatient stay. That's going to require a lot of cooperation with these independent surgeons. I've seen a number of organizations, my current client included, start working out these negotiations in types of contracts and ways to say, listen, if you want to continue performing here, because of NSA, we have to be able to have access to how you're charging, what your fees look like. And if you refuse to give that to us, then we're not going to be able to allow you to perform surgeries here. That particular approach is a little heavy-handed, but sometimes you do need that. What I've found is that my client in particular hasn't had to use that particular approach all too often. Most everybody's in pretty much agreement that this is the future. This is what's going to have to happen, and they're working very cooperatively together about that. One other thing that I might add, in addition to your surgeons and your other professionals, one thing that's typically overlooked is organizations that might use radiology reading groups that you'll contract out the read of an MRI or something like that. You'll have to also look at those fees for those reading groups and make sure that's included on your estimate as you go forward. So we always think about the surgeons and the independents that are coming in performing services, but we typically forget about the things on the other end, which is after the service has been performed in your organization, who is going to read that MRI, and then how we're making sure that we're having that information presented to the patient before it's done as well.
Yeah, Tim, that's a good point. You've got those ancillary providers, the radiologists, the pathologists, maybe your anesthesiologists in some areas if they're doing that, or even a cardiac surgeon if they're reading an echo after the fact. So I think those are all good points. I think the other, I'm in a similar boat as Philip. We're an academic medical center as well. So although we're not a closed medical staff, it is, for lack of a better term. So we don't have a whole lot of external providers coming in that are not through our faculty School of Medicine. But the one thing we are doing, even with them, which is a challenge because we are two different entities, is we still have to create some sort of an interface for them to be able to send their charges over to us. So we are actually working with Epic to create an ADT and an SIU message that will be coming back over. So we'll have access to those charges. I think it'll be interesting because Epic doesn't always like to talk Epic to Epic for whatever reason. So it'll be interesting to see how this evolves over time with those providers. But to the second part of the question about what they should consider when moving to Epic estimates, our experience has been that you really have to decide when you're using a template versus historical data, and the amount of analysis that you need to do on the back end or really the front end before you get started is pretty heavy. But once you start to kind of get a sense for what is a more standard, like an MRI or an ultrasound or an X-ray, those are the things you can create something more of a template off of, and you're just always using that same thing. And then as your charges change, then that updates with it. It's the historicals, I think, that get a little bit more challenging when you come into the therapy space or any type of a recurring series, because, you know, those can be so varied on how often a patient's treatment plan is really determined. So you have to be very careful with those. We're still working through a lot of the bugs that we have in our therapy space, because of those differences, whether it's a combination of OT and PT or is speech involved, or, you know, where do all those different pieces land for that patient's particular treatment. But I think the other thing to really focus in on is find those things that the system can auto-finalize on its own. So again, you don't have to touch it. You know it's good to go. Automate as much as possible so your team can really spend time focusing on those that need a little bit more of a critical eye and a review of, so you can finalize those that are going to be more correct and within that wiggle room of an error or accuracy rate.
I think I just also would want to plug with you guys is, you know, it's not just patient access focused, and it's not that, it's full rev cycle. So you do have to bring in your clinical departments to get estimated time frames of how long something takes. Your revenue integrity team should be doing a big lift for you of this to be able to go and do the pricing analysis and break that down, and which fee schedule should be pulling from what for IT and things of that nature. And also being able to say, hey, this is the average surgical timeline for this, and this is what we would say case rate, things of that nature would be. So I think this is a space that you really do have to partner across. We see it really led by patient access because it's patient facing, but really in the background, you need to be making sure that your other key leaders and team members are actually fully engaged in taking their portion of the ownership of it as well.
Agreed.
Highly
collaborative.
Build bit. Also make sure that you have a very well built, and I would say healthy RTE, or real-time eligibility for the non-Epic folks. So just making sure that you are able to pull back the necessary benefit information from the insurance, but also know where to strategically place that within the benefit collection screens, because the estimate is really driven from those particular screens and those fields within those screens. So having that build down, and then having I would say at least twice a year review of that build to make sure nothing has changed or their stuff has moved around from the data input perspective on the 270, 271. That is extremely important when you get to the point of how you're trying to not only explain the estimate to the patient, but make sure you're having accurate information go to the patient.
Yeah. You know, the other thing I forgot is if you are not already scheduling off of an order, you will have to make that transition. So another key change management feature, if you have not already put that workflow into place, you will have to do that with this to be successful.
So because we are near out of time, actually, we are going to hold the next question and bring it back for a future episode. And maybe Philip and Stephanie will actually get your guys' take on it and be able to plug it into that episode as well. But for everybody, that's it for the Wilshire Lab.
Yeah, thank you, Stephanie, Philip, and Tim for joining us today. Pleasure having you. And just so that our listeners can contact you with questions, or if they want to connect on like a social media website, what's the best way to get in contact?
Yeah, so there's a couple of different areas. So with NAHAM, we are available on Instagram at NAHAMDC. We're also on Twitter at MyNAHAM. We are also on LinkedIn as NAHAM Headquarters. And we're on Facebook at National Association of Healthcare Access Management. And then there's the good old-fashioned website of naham.org. And then for me personally, you can connect with me either on email, which is stephanie.benintendi@childrenscolorado.org, or I'm also on LinkedIn.
Same. I'm on LinkedIn. There's only a few Philip Quicks out there, so I'm the access guy. If a few of us come up on LinkedIn, message me, connect with me there. Also, you can connect with me directly via email, which is Philip_N as in Nicholas _Quick@rush.edu.
Yep, and then I'm on the Wilshire Group website, the wilshiregroup.net. And then my email is t.holland@thewilshiregroup.net, and I'm more than happy to connect.
All right. Well, Daniel and team, I think that's it for us today. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or find us on Twitter at Evan_Wilshire. Daniel can be found at Daniel_TWG. The Wilshire Group is at TWG Health. For us on Facebook at the Wilshire Group or on our Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out on YouTube at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on a topic, email us at thewilshirePodcast@thewilshiregroup.net.
The best way for you to support this podcast is to rate, review, and subscribe. We'll see you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.